I'm going to talk a little bit about, firstly, about the importance of psychological support in the perinatal period, and then to talk to you about many of the referrals that we get of women patients. So to begin with, I'd like to speak about the importance of providing psychological support in the perinatal period. Pregnancy, birth, and the postnatal period is such an important time physically and psychologically for both the mother and baby. Counselling at this time can help protect women from deepening depression and anxiety with consequences for their long-term mental health. For the baby, the physical and psychological care from the mother or significant caregivers can have a lasting impact on relationships in the future. The baby internalizes these relationships from very early on, whether they are nurturing and loving ones or neglectful, abusive ones. This then affects how they relate to others throughout childhood and into adulthood. The importance of this early attachment and relational behavior to others is shown in the work of several psychoanalysts. For example, Bowlby in 1969 talked a lot about it, Klein in 1940, and Winnicott in 1973, and there are many, many others afterwards. Pregnancy for most women raises many thoughts and feelings about themselves, their identity, how they were parented, and what sort of mother they would like to be. Many women, with the support and help of their partner, family and friends, and support networks, will find ways of managing this transition to parenthood. For some women, pregnancy might trigger psychological difficulties, or it may exacerbate pre-existing mental health issues. In England, the Perinatal Mental Health Services report for London in 2017 highlighted how important it was to provide psychological support and interventions to pregnant women from women's health counselling services and specialist perinatal mental health services. In my experience in the service I work for, we have noticed that pregnancy is a time women are often much more open to counselling services, and it does feel less stigmatising and more acceptable. Psychological input at this point plays an important role in preventing potential psychological breakdown later in life. This is the time when the baby learns about attachment and relating to others. A mother, for example, who is anxious and depressed in her pregnancy may not be able to relate to the baby she is carrying, respond and recognise the baby's needs. In turn, the baby may learn that whatever way it responds, it does not get any reaction from its mother or caregivers, and it then either becomes less responsive, cries more, or appears more anxious. This in turn can be the beginnings of a less helpful way of relating to others. In our service, we see women of all ages, from late teens to women in their 40s, women from different socioeconomic backgrounds, different ethnic groups and religions. We see asylum seekers and refugees, women who identify as heterosexual and LGBTQ, women who are disabled and neurodiverse, and women who have partners and women who are single. Women are referred to our service for several reasons. Some of these are historical and some have emerged for the first time during pregnancy. So first of all, I'm going to talk about some of the historical reasons. And these include women who've had previous mental health problems. This includes anxiety, depression, eating disorders, post-traumatic stress disorder, to just name but a few. Often the pregnancy will exacerbate these conditions, and the service I work for does not offer counselling to women who have had severe mental health problems, like psychosis, bipolar, borderline personality disorder. These women are referred to the specialist mental health service and are under psychiatrists and psychiatric nurses who monitor their condition and medication and provide the appropriate therapeutic support. We liaise with these specialist services for some of the women we work with, and we cross-refer. Women are referred who've had previous loss of a baby through a termination, miscarriage, or stillbirth. For these women, the new pregnancy raises anxiety and fears of a repeated loss. This can cause added stress in the pregnancy, and it can prevent the woman from becoming attached to the baby for fear of possible loss again. This may result in a feeling of detachment and inability to relate to her baby, which can in some cases result in further difficulties after the baby is born. Sometimes women who have had a loss have further difficulty, have not processed and found a way of living alongside the previous loss. This can then result in the next baby being related to as a replacement baby. Such a situation can have long-term psychological consequences on the baby that carries this. Psychological interventions during the pregnancy can help considerably in preventing future psychological difficulties for both mother and the next baby. Women who have had a previous traumatic birth and women who have had complications in birth are referred. A woman may never have spoken about what happened at her previous birth or may have repressed that experience only to find it re-emerges as she is about to give birth again. Having counselling can help her process what happened previously and understand her underlying fears so that she feels more in control of her emotions. It can also, in practical terms, enable her to think with members of the multidisciplinary team better ways of managing the birth and feeling more in control of what happens. Many of the women that are referred to our service are those with a history of sexual abuse, domestic violence, and safeguarding issues. Women referred may have experienced discrimination based on race, gender, sexuality, disability, or religion. Some women referred have a history of previous postnatal depression and are fearful this will reoccur after the next birth. Having a counselling space to explore their previous postnatal depression and to discuss alternative strategies with the counsellor of preventing a reoccurrence is important preventative work for both mother and baby. Other women are referred to our service as they have a history of complex relationships, especially with their own mothers, and find attachment issues problematic. So going on to a second reason for women being referred to our service, these include a number of areas. Some women have fears of becoming a parent. This may be related to their own experience of being parented and their fear that they will repeat the experience they had of an abusive or neglectful parent. They can express ambivalence about the pregnancy, wanting a child, but also being fearful about the responsibility of parenthood, the loss of professional identity, loss of financial independence, the demands of a dependent baby, the loss of their past life and spontaneity. All these thoughts and feelings can produce anxiety, stress, and depression. Having a space to speak about their fears openly without being judged often helps women feel more in control of their feelings. Relationships with partners, parents, or friends may change during a pregnancy, changes that they had not predicted. They may feel isolated, have little or no network of friends. They may suffer from antenatal anxiety and depression. This might be a new experience, and it might produce fear and panic attacks never experienced before. In my service, we offer psychodynamic counselling, cognitive behaviour therapy, and a mixture of both. The psychodynamic counselling is focused on attachment and relational work. In this approach, we explore how the present issues relate to past experiences, in particular to early childhood experiences. We explore the unconscious processes that are at play in producing, for example, the anxiety or the depression. In cognitive behaviour therapy, we are more focused on the present and offering various strategies of managing feelings. These include things like mindfulness, relaxation and breathing exercises, challenging negative thought patterns and reframing these thoughts, distraction, desensitization, breaking down problems into more manageable areas, and visualization. I thought I think I've got a bit of time to just give you a brief example of a composite case we included in the book that Michelle spoke about, using a psychodynamic approach. So I'm just going to sort of read from this. Dee is a woman in her early 30s, originally from New Zealand. This was her first pregnancy. The pregnancy was planned and much wanted. She lived with her partner, and she was referred to the Women's Health Counselling Service as she was experiencing anxiety, low mood, and insomnia. She had experienced some anxiety and stress related to her work in the past. However, she was surprised to find herself feeling psychologically distressed at a time when she imagined she would actually feel excited and hopeful in her first pregnancy. There were several strands to Dee's symptoms as we gradually explored her thoughts in the counselling sessions. It transpired that although she very much wanted a baby, she felt ambivalent about the huge change this would mean in her life. She felt guilty about acknowledging and expressing these feelings, as if by admitting them, they would harm the baby and she would be punished. Her identity was bound up with her successful career, and she feared the loss of status and position that could result from maternity leave. The counselling aimed to normalise these feelings, as in fact many women in her position have similar thoughts and feelings, in particular acknowledging negative as well as positive feelings about the pregnancy helped Dee to start to appreciate the complexity of her emotions and to come to terms with them. It was also important to explore that having thoughts and feelings did not mean they transformed into reality, and that it was beneficial to express them rather than act upon them. Dee felt that she would damage the baby psychologically by admitting she felt ambivalent. It emerged in the counselling that Dee's mother had given up her own career to look after her, and she had expressed some resentment and anger about having done this. Dee was consequently worried that she may have the same feeling towards her own child. In the counselling sessions, it transpired that Dee had very high expectations of herself and was a perfectionist. She wanted to have the perfect natural birth and to be the best mother to her child. She was inhabited by a highly critical and judgmental internal voice. She also liked to be in control. All of this was increasing her anxiety, low mood, and insomnia. And we explored the origins of her perfectionism and then looked at the underlying unconscious fears. She explained that both her parents had high expectations of her as a child. They wanted her to excel at school and were very critical of any failure. She had internalized these views, and they had become part of the way she perceived herself and the pressures she put on herself. She had not been aware of this, and she was then able to see how damaging this had been for her and could potentially be to her child if she repeated a similar pattern. It transpired that her perfectionism was a defense she used unconsciously to hide her fear of weakness, vulnerability, and falling apart. These fears related to her mother, who during the whole of her childhood and teenage years had suffered from various illnesses and had issues with mental health, to the extent of at times being an inpatient in a psychiatric hospital. For Dee, this meant she felt pressure to be strong and resilient, unable to share with others her fears of what she considered her weakness. This exacerbated her anxiety and added to the stress she placed on herself. It became apparent that she held an underlying fear of experiencing similar mental health problems to her mother, and she had to defend herself against this possibility by repressing such thoughts. Instead, these thoughts emerged as anxiety and low mood. And being able to consciously voice her thoughts and feelings openly in a safe and confidential setting, these fears became less powerful. She could begin to see that by acknowledging areas she perceived as a weakness or failure, she could be more open and intimate with her partner and friends, and feel less alone. She saw that by expressing her vulnerability in the counselling sessions, she hadn't fallen apart or become mentally ill, and neither had her counsellor. This was especially important as it contrasted with her experience of her mother, who had been unable to cope in this way. Dee became aware that the way her mother experienced physical pain had affected her so that she had internalized a terror of such pain, which was then transferred onto her fears of how she would experience childbirth. Her mother had unconsciously instilled in her an idea that health professionals could not be trusted and that she would have to manage on her own. Wow. I hope that gives you a sort of taste of the type of sort of counselling work that comes our way in the Women's Health Counselling Service.